Welcome to Pediatric Sedation and Anesthesia course. My name is Gary Badger. I'm a professor of pediatric dentistry in the Department of Pediatric Dentistry at the University of Texas School of Dentistry in Houston. Today we are going to be discussing module number 14. I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you will receive instructions regarding taking the exam. Section Overview. This section presents information to create an understanding of the continuum of sedation through which the dentist can make appropriate choices of pharmacologic agents that can be safely and effectively used for the various pediatric dental sedation procedures. This course is part of a 16-hour comprehensive program designed to meet the requirements of Texas State Board of Dental Examiners Rules 110.17, Sedation Anesthesia of Pediatric Patients. Today we're going to be discussing Module 14, Pediatric Case Selection and Reference Behavior Scale. Images used in this presentation are taken from non-copyrighted sources in electronic media and attributed as possible. The de-identified images are provided as an educational resource to illustrate techniques and procedures for clarity. Objectives are to understand pediatric case selection criteria and to understand pediatric behavior scales. Pediatric sedation case selection. The selection of children for sedation is based upon the needs of the child, not only for the dental needs, but for their social needs. What sedation protocol is selected is based upon social expectations. For example, how the patient reacts to certain social situations that demands their responses be altered by sedation to accomplish treatments designed to improve their oral health. Selection of cases. Children that have developed social skills that allows them to integrate with professional situations, such as pediatric dentistry, pediatrics, or family physicians, may require little psychological assistance to adapt to the situations. On the other hand, children that have not learned the social skills to be comfortable in those environments and like social situations need beneficial support. It is possible that children are becoming less socialized and therefore more reluctant to interface with others. If so, there may be more sedations than less because of the inability to cope with the stress generated within their minds. The inability to develop coping skills for dental procedures renders them unable to suppress emotional responses and thus require sedation. Cases self-select themselves. Pediatric case selection. Patients who are ASA classes 1 and 2 are frequently considered appropriate candidates for minimal, moderate, or deep sedation. Children in ASA 3 and 4, children with special needs, and those with airway anomalies or moderate to severe tonsillar hypertrophy present issues that require additional and individual consideration, particularly for moderate and deep sedation. Practitioners are encouraged to consult with appropriate subspecialists and/or an anesthesiologist for patients at increased risk of experiencing adverse sedation events because of their underlying medical surgical conditions. Special health care needs. Any physical, developmental, mental, sensory, behavioral, cognitive, or emotional impairment or limiting condition that requires medical management, healthcare intervention, and our use of specialized services or programs. Many causes and creates limitations of major life activities. These are examples of special patients, and it's important to understand that they are integrated into our society, and we must provide for them an exceptional opportunity for receiving care as well as average children. Special patients. Underlying the special patient's oral conditions are associated medical conditions that may place the patient at risk for sedation. Consultation with their primary care provider is essential to determining whether the medical condition will affect the sedation and/or dental care. It is best to send a consultation request with the following information: the name, age, and date of birth of the patient, the anticipated dental treatment, and expected time and date of treatment, anticipated sedation level, drugs, dosages, and duration, medical issue of concern, medical issues being used and dosages, condition of the patient at dental examination. The consultation referral document can be a protocol file for computer printing. Patient selection assessment. The pre-sedation patient risk assessment should include a history and examination that highlights issues important to anesthetic administration, as well as the issues surrounding the chief presenting complaint. Number 1, history. Concurrent medical illnesses, respiratory illness, volume depletion, fever, medications such as dosage, frequency, interaction with sedation, drug protocol must be considered in the patient selection process. If patients, for example, are taking medications, will that medication interact with the sedation drug therapy? And if so, we need to know how it's going to be affected. And concurrent medical illnesses such as respiratory illness, volume depletion, dehydration, and fever are going to contribute to the illnesses as they progress. Allergies, interaction of the patient with sedation drugs, and the sedation drugs and allergic reactions may send the patient into a deeper level of sedation than we prefer. Prior adverse reactions to anesthetic or sedative agents, such as paradoxical reactions or prior hospitalizations. Paradoxical reactions are those actions that occur in the behavior of a child where they may become inconsolable due to the administration of the drugs, and it releases their inhibitions on their own behavior. And so if they become so stimulated, then it's going to allow them to feel uncomfortable, and they may start crying and be inconsolable, not even recognizing their parents. Prior hospitalizations and the utilization of similar drugs or the same drugs to sedate the child may indicate how the response is going to be from that particular child. What would be respiratory symptoms that give us a clue that the patient is having trouble catching their breath? Well, number 1 would be breathing fast. We know that children, particularly younger ones, breathe at a faster rate than older ones, and it's important to see, is this an abnormality that the patient is breathing fast? The positioning they make of themselves to receive and exchange air will be a clue to how they're feeling and whether they're being comfortable or not. Retractions, that's seeing a deeper outline of the rib cage or ribs than what is normal. This means that the intercostal muscles are working very hard to ensure that the inhalation and expiration of oxygen is occurring at a frequent level to maintain the level of oxygen saturation necessary to support that individual. Coughing could be frequent. If so, then this patient may have some asthmatic condition, or vomiting may occur along with it. And these are symptoms of respiratory illnesses, and need to be avoided in considering sedation for the patients. And the activity that's going on with the child, they are not playing or being their usual self, then this could be a symptom that there's some underlying condition that is not allowing this child to be involved in the social circumstances. Symptoms of respiratory illnesses are available by observing carefully the patient. Is the patient talking? Infants and toddlers, for example, are quiet and not making normal sounds. Older children are unable to talk normally, having to catch breaths between words. Wheezing is a high-pitched whistling sound heard when breathing out. If we recognize this, then we know the patient has an upper airway obstruction. Stridor is a harsh, raspy, vibrating sound heard when breathing in. As it progresses, it can sound like a seal, particularly with coughing. Fever, keeping track of the number of diapers an infant or toddler is using, or when the last time your potty-trained child went to urinate, gives you an idea of the function of the kidneys, but also the ability of the patient to urinate and develop urine as a result of some infection may not be present. So recording the number of diapers, recording approximately what the anticipated volume would be. Volume depletion occurs when a patient has fever accompanied by nausea and vomiting, can rapidly cause dehydration. If this is occurring with a child scheduled for sedation, the child must be rescheduled. Volume depletion can be detected by assessing capillary refill. This is done by squeezing the nail bed, and the blanching on the nail bed should disappear within 2 seconds. If longer, then the patient is depleted, and that's evident, and rehydration must occur. Fever is a temperature above 100.4 degrees or 38 degrees Celsius. Infection is the most common cause of fever in children. Common viral and bacterial illnesses like colds, gastroenteritis, ear infections, croup, bronchiolitis, and urinary tract infections are the most likely illnesses to cause fever. Scheduled sedation of children must be rescheduled. Children that are taking medications must be evaluated for sedation treatment by their primary physician consultation to ensure that an NPO or nothing by mouth status can be observed. In addition, the dental provider will want to know if the medication has any interaction with the sedatives so as to avoid augmenting the drug or interfering with its action. Allergies. Allergies can cause respiratory symptoms that increase risk of sedation, and medications for allergies may have a synergistic effect with sedating drugs. One must determine the interplay of these situations in order to safely administer sedation drugs before scheduling. History of prior sedations and hospitalizations allows us to have a focused evaluation of prior hospitalizations or sedations, and the outcomes may elicit a history of hypoxia, hypotension, or obstruction during a previous treatment. If such a history is uncovered, it is necessary to consult with a subspecialist to determine the cause and treatment in order to avoid a repetition of an untoward sedation event. Obstructive sleep apnea. Questioning a potential sedation patient about sleep apnea, moments when respiration is suspended, is essential to lower risk of sedation. When children become overly tired due to lack of sleep at school, performance decreases, irritability occurs, and certain physiologic parameters are affected. Determining if your patient suffers from this condition will reduce your risk factor. Patient selection assessment. When examining a patient, one must look for airway difficulties and the possibility that swallowing may be interfered with, and an easy gag reflex resulting in nausea or vomiting. A history of sleep-disordered breathing or snoring. Is that available? Is that something that's happening with this child? Major medical issues with physical abnormalities in some and neurologic problems in others may interfere with the sedation process, and as a result, these patients must be excluded from typical outpatient surgery that involves sedation. Last, solid or liquid intake. There will be further discussion regarding this, and physical examination would be the next category, where cardiorespiratory status is evaluated and whether the respiratory tree is interfered with in any of its function, and then resulting in cardiovascular abnormalities that may be occurring regularly. Is the airway anatomy and function properly aligned with sedation? An assessment exclusions may determine whether these patients can be sedated. Exclusion criteria include difficult airway syndromes, abnormal faces or abnormal development or positions of the nares and the mouth, dentition, or the neck. Is there any interference with the airway in any fashion due to abnormal development? Is sleep apnea occurring? Is stridor, inspiratory stridor occurring? Is there airway obstruction due to the collapse of the soft tissues within the vascular and within the airway passageways due to soft tissue losing its muscle tone? Is severe asthma present? If so, then apnea is a possibility. Are there any tracheal abnormalities? Is it allowing insertion of an endotracheal tube? Is there severe cardiorespiratory disease, either congenitally or acquired? Is severe gastroesophageal reflux apparent in this child, causing erosion of teeth and the inability to swallow well? Patient exclusion criteria include severe obesity, raised intracranial pressure, severe neurological impairment, and or bulbar function, malignant hypothermia in infants less than 6 months old. Selections of patients for sedation is based upon 1. The ability to tolerate outpatient dental procedures by maintaining limited movement, tolerant of uncomfortable to painful procedures such as injection to extractions, and behavior that is not disruptive to patient compliance with instructive directives. 2. The patient with compromising medical conditions that will not allow outpatient procedures such as neurological illness, cardiovascular conditions, respiratory compromising conditions, obesity, limited cognitive ability, bleeding disorders, allergies to medications that may be used for sedation, genetic disorders that compromise the patient, and other conditions that elevate risk. 3rd, developing children may be at risk for alterations in brain development, and recent evidence, mostly animal, suggests that children under the age of 3 should not receive sedation or general anesthesia for durations greater than 3 hours for elective procedures. The United States Food and Drug Administration has published a warning regarding repeated or prolonged anesthetic exposures exceeding 3 hours in duration for children younger than 3 years of age. Animal studies of anesthetic effects on developing brains. This is a diagram showing the maturation occurring from left to right, and that the brain has the opportunity to have neurons that during the intermediate stages of development are specific targets for anesthesia-induced apoptosis or destruction of the cells.
because it may skip the beginning and skip the end. The anesthetic susceptibility can destroy neuroblasts and immature neurons, leaving the patient somewhat stunted in its ability to deal with the effects on the brain at that location. And as a result, the maturation of the child is interfered with and their neurological activity. 4. The reality of treating developing children that have not reached the age at which certain developmental conditions or disabilities and/or medical or physiologic and physical conditions have been identified establishes a risk level for undiagnosed conditions which may cause an untoward event during pediatric sedation or anesthesia. Selection of a sedation patient. Once the selection of a patient has occurred, after a thorough review of the medical history, preventive strategies for a safe sedation experience must be in place. The time of day the sedation is arranged, in fact earlier for younger children, the setting where rescue equipment is available, the facility has a rescue cart with current medications that are there, keeping current drugs in place, and adequate oxygen equipment is available and functional. All consents must be signed and dated by the authorized caretaker and/or a patient and acknowledged by initials or signatures of the providers. All treatment plans are understood and consented, expectations of outcomes explained, risk, procedures, and alternatives discussed, and all questions are answered. Protocol for patient selection. The patient, who is older than 2 years old, is examined orally, if possible, to determine the extent of the pathology. If at least 1 to 3 severe carious lesions are evident and associated with complaints of discomfort or pain, and the patient exhibits fear and anxiety, resistance or belligerence, this patient may be a candidate for sedation or anesthesia. Informed consent of the parent is necessary for this treatment. 2. If informed consent is denied by the parent, then preventive therapy is indicated until consent can be achieved. Therapies include fluoride, including silver diamine fluoride, rinses, gels, improved brushing and diet, or consideration for treatment under general anesthesia, either OR or IV. Behavior scales. Children are evaluated for behavior at their dental visit, including their cognitive level, coping skills, and temperament, based upon observation, social ability, language skills, and parental relationship. Several behavioral classifications have been used to label the cooperativeness of the children. The following are some of the most common. The Frankel scale is rated 1 to 4, and the Frankel score of 1 indicates that a patient is definitely negative, refusing treatment, defiant, and unable to cooperate. If the patient is a Frankel 2, the patient is negative, a bit reluctant, timid, and uncooperative. A Frankel 3 patient is positive, accepts treatment, but may be cautious or reserved, follows directions. Frankel 4 is definitely positive, good rapport, interested in dental procedures, laughs, and enjoys. Frankel score can be used linearly, and we'll describe it here for you. The patient's behavior may be documented at a point in time or listed as a commentary over time. For instance, during the exam, the patient may exhibit F4 behavior during the prophy, F2 behavior and with nitrous becomes F3, and during injection, F1, returning to F3 during treatment, and ending at F4 when discharged. It can be documented as follows. The patient starts off as an F4, completely comfortable and relaxed, and they get ready to have their prophy. They become F2 with the sound of the handpiece and the cleaning of the teeth. The patient moves to F3 and is administered nitrous oxide. The patient's becoming more disruptive to a F1 during the injection and sliding back to F3 for required treatment, and to an F4 is very happy upon discharge. If the patient is undergoing sedation, these notes can be recorded on the time interval in the sedation record and allows one to refer back to the behavior of the child in a linear fashion over time and to understand what it was that caused the disruption. In this particular instance, the linear diagram shows that F1 occurred during the injection and that as the patient progressed to the treatment, became much more cooperative. Here is another behavior scale, behavior rating scale, where examiners allow determination of 3 behaviors on a numerical scale: sleep, movement, crying, and then a combined overall behavior. The score number 1 is for a fully awake and alert patient. If the patient becomes drowsy or disoriented, they get a 2, and if they're asleep, a 3. Movement is evaluated with violent movement interrupting treatment. That's a score of 1. Continuous movement making treatment difficult is a score 2. Controllable movement that does not interfere with treatment is a 3, and a 4 is no movement. Crying or hysterical crying that demands attention is a 1. Continuous persistent crying that makes treatment difficult is a 2. Intermittent mild crying that does not interfere with treatment is a 3, and no crying is a 4. The overall behavior then is evaluated. If the treatment was aborted, it's a 1. If it was poor where treatment was interrupted only partially completed, is a 2. If the treatment was fair, treatment interrupted but eventually all was completed, their score is a 3. And if they were good, difficult, but all treatment was performed, it's a 4. They are very good with some limited crying, it's a 5. And if they're excellent with no crying, they're a 6. So the examiner observations allow determination of these 3 behaviors on a numerical scale and can be totaled for determination of the behavior rating. Ohio State University Behavioral Rating Scale is similar. This presentation of its results is given by the percentage of a given score observed during a session of dental treatment requiring treatment, and each criterion is given a percentage for a total of 100%. Was the patient quiet? Were they crying with no movement? With movement, without crying, or struggling? This is a behavioral scale called the Benham Behavioral Rating Scale. It's a modified version, has 5 of the original scores. By combining 2 scores, it is more reliably used and valid for research possibilities. Read down through this and see total cooperation is 0, mild protest is 1, protest is more prominent is 2, 3 is protest presence, real problems to the dentist, 4 is protest disrupts procedure, and 5 is just a general protest. These are scales that one can use to characterize behavior when the patient comes to the dental office. The behavior rating scale summary is each rating scale provides an opportunity to describe the observed behavior with a numerical score. This allows one to determine the behavioral progress of children over time and permits one to assign personal descriptors such as what plus or minus means in the Frankel score, and to be able to train auxiliaries to recognize how to assign times for treatment based upon this numerical score. The scores can be used to justify the application of sedation to a patient based upon acceptability of the rated score for treatment purposes. Other scales may be available, or one could create their own. It is obvious that negative observations guide one to prescribe sedation or anesthesia as an important tool to assist in the delivery of quality care. Behavioral assumptions based on appearance. How old is this patient? How old would we expect this patient to be cooperative? What is the medical concern? Does the patient have any medical condition that will affect how they interact with the treatment provider? What treatment is to be rendered? Does the patient take any medications? If they take medications, it may interfere with the sedation process. It may interfere with the patient's behavior. Does the patient have any allergies? If they have allergies, they may have a sniffle nose. If they have an obstructed nose, it may be difficult for them to breathe, accounting for the behavioral quality of the interview. Does the patient have any bleeding tendencies? If so, and teeth are planned for extraction, this may make us a little more retrospective on whether we should do this patient or not. Is the child a preemie? How does he do at school? If the child is a preemie, then there are long-term lung effects. And does this child have any? How does he do when he's at school? Does he do well? Does he play with siblings? Does he play alone? Does he have friends? Does he play sports? Does he have any siblings? Has he received dental care before? What do you think he will do when you ask the parent? Will they give you an opinion that's higher than you expect? Is he on grade level? Does he take any special classes?
Oh, wow.
Those are things that we would expect the patient to be able to show us. Here is a little patient that's receiving some care. You can see the patient's a little bit excited, but as an infant, they're doing fairly well. They sit still. Notice that the crying stops when the parent lifts the child up, and see what happens when the doctor looks at the patient again. So the stimulation is going on, and this is a pre-sedation infant exam, and it's going to be important to determine whether or not this patient should be sedated and with what medications. Records. Clinical exam is important, and achieving our goal of providing records that are totally diagnostic and relates to the situation occurs if we have pre-treatment records. For example, a pantograph, bite wings, or diagnostic models, or cephalometric models. Those are our cephalometric x-ray. Those are important records to retain within the dental record. Photographs with permission from the patient and de-identified become a permanent part of the record and can be used for teaching purposes as well as diagnose developmental conditions. A sequential treatment plan needs to be present and appropriate progress records noted within the records. If you need clarification of any of this information, please send an email to pace@uth.tmc.edu. Here we are in the reference section, and you want to continue to use these references to come up with some of these answers that will help you in your sedation with these patients. This completes this section of the course. It's time for you to take a short exam in order to complete the requirements for streaming video courses. And once you have completed that, the nature of the subject, you need to get a passing score of 80%. It's necessary in order for you to advance to the next section. Upon a successful completion of this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, you'll be instructed to take the exam, and a new set of questions will be provided. You'll have 3 chances to fulfill the requirements. If you're not successful, you'll be instructed to review this section again. Good luck on the exam. If you're ready to take it, the next section, upon the completion of the exam, you'll be provided a link to continue. If you wish to proceed at a later date, you will need to log in and no further payment is necessary since this is a continuum.